parts of viability. We'll talk a little bit about echo and MRI in more depth in what I do day-to-day back in Toronto, and that's nuclear cardiology. And then a little bit about how we can decide who will actually benefit from revascularization. So there are two parts to this question when we talk about viability. So the first thing is to look at the areas that are ischemic. By definition, an ischemic section of the myocardium is not receiving sufficient metabolite to meet demand. And the results of that can be stunning, which is a transient degradation of myocardial function. It can be hibernation, which is a long-term loss of cardiac function. And then eventually, if the problem isn't remedied, you wind up with fibrosis and myocardial cell death. And when we're asked to determine viable myocardium, we're really looking at two things. We're looking at the myocardium that can be salvaged either because it's ischemic and we can reverse that, or that's hibernating, and identifying the hibernating areas so that we can reverse that process as well. If you deprive the heart of blood, and this graph is showing along here, is shortening and myocardial blood flow. And as you decrease flow to 50%, you have a very significant decrease in shortening. What this tells you, no surprise, to those of you who've seen stress echoes, is when you have a cardiac patient under stress and has a narrowing in a vessel, and the blood is not sufficient to that section of the heart, it stops contracting as vigorously as the remaining segments, and that's how you make a diagnosis with stress echo. If you continually decrease the blood flow, you eventually wind up with a section of the myocardium that is not contracting at all and may look akinetic. It can also look dyskinetic, that is more of a function of thinning and fibrosis, but the segment, when it has a significant prolonged lack of blood flow, will simply not contract. This can be demonstrated in models. If you take a vessel and you acutely ligate a vessel, this is showing the blood flow dropping off rapidly. Before long, the actual regional wall motion will decrease, and if you leave the occlusion long enough, the section will completely stop thickening. It's also important that I separate the two values of thickening and contracting. Because the heart is a single organ, all the sections connected, an area that doesn't thicken can still move. And sometimes with an experienced eye, you'll look and think that that area is moving. The thing we look at, though, is thickening, because the akinetic segments may be pulled in from the normal functioning segments. And then when you release the ligand and the blood returns to normal, there is a period, and the length of this period will depend upon exactly how severe the insult was, the degree of normality of the myocardium before the insult, but eventually the heart will start to contract normally, and if the blood flow returns, the contraction may come back to normal. So study is essentially a delayed recovery of the region of the myocardium that is transient, occurring between a period of ischemia, which is followed by reperfusion. On the other hand, hibernation usually results when there is a sequential loss of blood flow, such as that will often occur in an area of severe abnormal atherosclerosis, sometimes after an occlusion. The vessel will recanalize, or may recanalize in such a way that the flow to the myocardium is extremely low. Not so low that you wind up with cell death and fibrosis, but low enough that after a while the heart enters a stage of what is called hibernation. And in hibernation, metabolism changes. The cells, if you look at the myocardium, it's akinetic, and it can stay hibernating for a prolonged period of time. Generally, in patients with atherosclerotic disease, that is not years and years. It's different than the examples mentioned before with a congenital abnormality, but it can be a very long time. And if the blood is returned, then the area of myocardium that was hibernating will slowly return to normal. Again, the length of return depends upon a lot of factors, but can be weeks to months before the section that had blood flow restored comes back to normal. So hibernation occurs after prolonged myocardial hyperperfusion, and it occurs in the absence of clinically significant ischemia. So when we're looking for viability, what we're looking for is segments that will be improved if we can return blood flow or normal blood flow to that territory. So it requires that we get blood flow back, that there be an adequate myocardial blood flow. It requires that the cells still have normal integrity, i.e. they haven't died and become fibrotic, and that there is some level of metabolism occurring in those cells that allow them to stay alive, and that stunning, and if you have recurrent ischemia, eventually you can have recurrent stunning that can become prolonged. And although it's not exactly the same as hibernation, it's functionally the same, that the myocardium is alive but not contracting. With the blood flow is then significantly limited, you wind up with hibernating myocardium. And if it stays hibernating, eventually it progresses to necrosis and scar. And of course, the problem with that is that the progression from hibernating myocardium to dead myocardium is a very arrhythmogenic process, and the patients will develop significant numbers of arrhythmias during that phase. And sudden cardiac death is common in patients who have significant amounts of myocardium in a state of hibernation. So, having told you that there is a variety of ways that the heart has damage after an interruption of blood flow, there can be areas of infarction, such as shown up here with very thin, scarred myocardium. That really you can't do anything about unless you're going to do surgical intervention or resection. You can have areas of mixed ischemia and hibernation, and the whole mixture occurs in a patient with atherosclerotic disease, such that really there is no single picture. You're going to have a large portion of the heart that may be ischemic, that's easy to treat, which you either with PCI or surgery fix those vessels, that problem solved. You're going to have a section of the heart that's dead and you can't do anything about that. And then mixing between, you're going to have this area of recurrent stunning and hibernation, and they both have the hallmark of abnormal left ventricular function. And the trick is how to find this territory here and separate it from these two territories. So, before we talk about this, we probably answer the obvious question, why would you bother to look for it in the first place? And I sort of alluded to that earlier. Some people would say, just revascularize everything. You don't need to do clinical trials on everything. This is a joke publication from Lancet that looked at why there are no clinical trials on parachutes, because nobody wanted to be on the blinded side of the trial. And you could argue that if you have diffuse disease and LV dysfunction, you should revascularize everything. Conceptually, that makes sense. If you can get all the vessels fixed, then probably that's going to be a good thing. But we know different from clinical trials. This is one of the early meta-analyses of patients with heart failure and viability. And essentially, he looked at two groups. Patients who had viable myocardium, by at that point would have been either PET or SPECT thallium testing, or non-viable myocardium, actually a bit of echo at that time as well. And then looked into the two groups at medical treatment and revascularization in each group. And the thing that jumps out at you is that if you have viable myocardium and you don't revascularize that territory, you do very badly. Your mortality rate is very high. From what we explained, the significant arrhythmogenic events that are going to occur during that. What's not appreciated as well is this side, that if it's non-viable and you revascularize it, there's a suggestion you're also not doing the patient any favors. It sort of makes sense if you think about it. You have to undergo the risk of surgery or the risk of angioplasty in an area that's not going to get any benefit. And so you basically just reap all the complications of the procedure without benefit. And so for these two reasons, these two halves of the graph is why we want to look at patients to determine whether there's any viability. This is actually just a breakdown of the data that I showed you, and there are different ways that we'll talk about to determine viability. I usually do thallium, magnesium, PET or echo, and there's also MRI, which I haven't put on here. And in each of these, the patients who have viable myocardium, depending on how they were predicted, have a high mortality if you just treat them medically. And those who don't have viability also have not an insignificant event rate if you try and intervene on them. So the objectives of this are to determine which patients have viable or hibernating myocardium. And the reason for that is because we know if we can practically reverse that by reintroducing blood flow into the areas that are abnormal, we're going to wind up with a reversal of LV dysfunction, a decrease of arrhythmias, and improved survival. So how do we go about detecting this? Well, there are a number of ways. And again, there are two things to think about when we're detecting it. Is the viability there? And is there a way that we can quantify how much? And the likelihood that we can identify it in a quantitative way increases the usefulness of this technique, because the more confident we are showing that there is significant as opposed to trivial territories are viable, the more benefit we're going to have after an intervention. So this is just a slide showing you the different ways this can be done. The ones I'm going to talk talk at the end, or nuclear, we're talking about PET and thallium imaging. This is a fatty acid metabolite that we don't have. It's used in Europe for determining viability. Viability echo is a very good way because it's relatively easy and not very expensive. You can do it in a lot of places. And contrast MRI, very sophisticated, also an excellent way to look at determining viability, but in practical purposes, probably not better than any of the other techniques. If you look at the existing data, and I don't have MRI on here, but MRI usually sits pretty close to where the Viability echo is. So you look at the sensitivity and specificity, you will see a spread. And the spread is predictable based upon the technology. Echo has a higher specificity because when you're doing Viability echo, or if you're doing a contrast MRI, you get the benefit of looking at contractility associated with the areas that you're trying to determine the presence of hibernation. And so the specificity is higher because you're going to see muscle that can contract. And if it can contract under Viability, then it will contract well after it has had blood flow restored. The sensitivity for Viability echo is a bit lower because of the fact that it requires a certain mass of functioning tissue to actually be seen as viable. In techniques such as PET, which has sort of the best overall balance, the specificity is lower because PET can see small areas of viable tissue that may be trapped within a non-functioning scar that even after revascularization is simply not going to get better. And so its specificity for improving regional function is going to be lower than echo because with PET, and the same as with thallium, we don't have a direct assessment of the contraction that occurs in that territory. If you look at regional function, again, global function, you see the same thing. Whether you're using the different nuclear techniques, whether it's SPECT, thallium, SPECT, Viability, or PET, you have a relatively good sensitivity and specificity. Specificity overall approaches that of the Viability echo. MRI generally sits over here somewhere just because of the fact that you have slightly better spatial resolution with MRI and you're able to detect areas that contract well, even better than echo. The sensitivity, as I described, is lower because these techniques can miss more modest amounts of myocardium that may also improve function if they're revascularized. So stress echo, this is what I really do here, so I'm not going to spend a long time talking about that. You're going to do this in patients, obviously, where there's a concern that you have an area that has been damaged either by infarction or prolonged ischemia. It's going to be an area that does not thicken normally. It's going to be an area, however, that should not be thinned and scarred because there's really no point in looking at viability in an area that already is thinned and scarred or obviously dead. And what you're going to do in that patient is you're going to give them an incremental dose of Viability and look at the recovery of function in an area that at rest was hypokinetic or akinetic. I'm not sure how good that looks on your screen. Up here in the apex and anterolateral wall is a region that is quite hypokinetic. It's not thickening. Each of these frames going this way and then this way is an increase in Viability in patients. And when we get to the higher dose here, the apex is still not doing very well. The area adjacent to the lateral wall is now thickening and moving. This would suggest that the patient has an area of myocardium that is hibernating, and the patient may do well with revascularization. Contrast MRI does somewhat similar, except with very much more expensive equipment, but it produces much nicer pictures. It gives you good anatomy, it gives you good specificity, and with the addition of the contrast, shows you areas that are inflamed or have high water content, which usually coordinates with scar. So if you have an area of the myocardium that's hypokinetic and severely scarred, that's not going to be an area that would be amenable to an intervention. If you have an area of the myocardium that's hypokinetic and there's only partial scar, then there'll be a good chance. And if you revascularize that territory, it will get better. So the first case here was given to my colleagues in the cardiac MRI, Dr. Wintersberger. And this is a 55-year-old patient with three-vessel coronary disease, grade 4 left ventricular dysfunction, and they're planning whether or not revascularization bypass would be useful in this patient. These are a series of cine MRIs, and this area here, you can see is thin, and you look at the various images, it's also quite hypokinetic, and the question is, whether or not that territory, if it was revascularized, the patient would benefit. Once you've had a look at that and realize in your mind the area that's hypokinetic and somewhat thin, the question will be, when you look at the contrast images, is there full thickness myocardium? Is it normal? Is there areas of gadolinium uptake that are significant, suggesting most of it is scar? And that's the next picture. So if you look at not the white on the inside, the white line is just right there, you'll see on this image especially that there is about a 50-50 split in wall thickness between the white, which is gadolinium, and the dark, which is the myocardium. And this suggests that in that territory, less than half the wall has it's not transferred, probably not a good word, less than half the wall is infarcted, and so that patient would do well with revascularization, because even though the whole wall is hypokinetic to akinetic, only half of it is actually scar. And if blood flow is restored, you'd expect that after the hibernation period is interrupted, that part of the myocardium will contract normally. This is another patient, case 2. This patient is 74, he had a bypass in 84, redone in 95. He presents with fatigue and angina, and the question again, does he have hibernating myocardium? The ventricle, left ventricle here is quite dilated. This is up at the level of the mitral valve. As we move down, it comes more towards the apex. These are papillary muscles here, the arteries on this side. And this area here is probably the area of most interest. As you look through the slices, this region here looks somewhat thinner. It's virtually akinetic as opposed to the rest of the ventricle being hypokinetic. And if you then look at the gadolinium injection, too far. If you look at the gadolinium injection, probably best here and here, you can see that there's very little lack within the white part. The white is the gadolinium, which is a marker for in this particular instance, for fibrosis. And so pretty much the entire wall is fibrotic with small islands of tissue, but very little likelihood that if you revascularize that, those few small islands of tissue would be a benefit to the patient. And so this is a patient they would say does not have significant hibernating myocardium. They wouldn't, on the basis of this particular image, recommend them for revascularization. So we're going to spend the next 15 or so minutes talking about the use of nuclear cardiology for viability. There are a number of ways that you can do it. The common ways that we do is with either thallium or FDG. There are, of course, other agents of use. Estidating can be used, and these more sophisticated PET agents can be used, but the half-life of it is impractical for a lot of sites. So thallium is actually the simplest. Thallium is an element from the periodic table. Your body treats it like potassium. It's used obviously for thallium stress testing, but also is very useful for looking at viable myocardium. Thallium is only taken up and retained in living cells. So when you're looking at determining viability with thallium, you need two things. You need a vessel or a blood supply that's going to get the thallium to the tissue, and you need living tissues to retain the thallium. So when we do thallium viability imaging, there are two techniques. We either do a rest redistribution, where we inject the thallium, we do an image in 10 minutes to get a baseline, and then we come back sometimes 8, 10, 12 hours later. And the purpose of that delay is to give the thallium as much time to get into the area of hibernation so that it can be taken up and we can see an increase in uptake. That is a technique that's used widely where I work at Toronto Western. We actually use an infusion where we infuse the thallium for 2 hours. So we do an image at 10 minutes and 2 hours, and then again at 24 hours. And the whole purpose of both of these, whether you're doing a rest redistribution or a rest reinjection, is essentially to get as much thallium, to use the kinetics of the tracer, as much thallium as possible into the tissue. That assumes that there's living tissue with a blood supply. And this is an example here of a patient. This, I'll just use this, these are just different views of the same patient. This is the stress test. The patient was given Versantine. This is the rest. And the key here is that there's really no difference. So there is no redistribution in that territory. For all intents and purposes, you would think that it's a scar. When the thallium is re-injected and we In PET, there are a number of agents that we can use because of the half-life issues. The only practical one is F18 glucose or FDG. The other agents, you really need to have a cyclotron on site. We don't have one of those yet, so we need to use agents that will last long enough to actually be practical. In hibernating myocardium, as I discussed, metabolism shifts from free fatty acids to glucose, and the areas of hibernating myocardium are avid to take up sugar. FDG is a fluorodeoxyglucose analog that actually is permanently attached to the cells that take it up, thinking that it's glucose. It's got a fluorine 18 molecule attached to it, and we're able to image cells that are metabolizing glucose. The problem with PET agents is that the good thing about PET agents is that they're high energy, so that they're able to image patients, even obese patients well. The problem with all of these agents is, one, they have to be made a cyclotron, which is expensive, and the second thing, they all decay by what's called coincidence, which means that they became 180 degrees each one gives off a photon 180 degrees, and it needs very expensive equipment to detect. So if you get around that problem with PET imaging, it's an excellent way to image myocardium. And again, as I discussed, the issue with picking agents is the half-life, and we use F18 because it's got a half-life of 1.98 hours, which means that if you make a large dose of cyclotron, which is about an hour from our hospital, you can usually get 3 or 4 patients done in that day before all of it's gone. When you're using things such as O15 oxygen, you pretty much have to make it and inject it almost simultaneously, because with a 120-second half-life, it's virtually impossible to transport it anywhere. So we talked about that, and a little bit about patient types. Obviously, many of the patients we see are diabetics, because that's one of the commonest risk factors for coronary disease, and one of the commonest reasons they have large infarctions with areas of hibernation. We also have non-diabetics. For both of them, we want the body to be desiring sugar. So for diabetics, we'll put them on a insulin infusion so that we can bring their blood sugars down. If we inject the tracer when the blood sugar is high, there's too much free glucose floating around, and we hardly get any of our tracer taken into the heart. So it's called a glucose clamp. A patient is given a glucose infusion to maintain their sugar, and then insulin is infused to bring the sugar safely down to about the 5 range. And then the FDG is injected, and it will be taken up in the myocardium. One of the other benefits of FDG, which you don't have as much with stress echo or with MRI, is that the data is collected pretty much at leisure in 360 degrees. So we're able to image the heart in multiple planes. That's why it's called tomographic imaging. The usual planes are short axis, and you can see the models on top. We have the anterior wall, the septum, the lateral wall, and the inferior wall. This is the septum and the lateral wall. This is the anterior wall, apex, and inferior wall. In the standard PET image, we look at all of these. And this is what we're looking for. In this case, the top panel is rubidium, which you can think of as the flow agent. This is looking at the myocardial flow, and you can see this is a short axis view. There should be a donut, half the donut's gone. This portion here, there's nothing there. With FDG, the donut becomes more complete, and there's a significant increase. This whole area that is present here and absent there, we call mismatch, and this mismatch is the area that's alive and hibernating, that's metabolizing glucose preferentially. This is another example here, again, of the same thing. On this side, this is a perfusion agent. In this case, it actually is sestimidi, and you can see that in the long axis view, there should be a horseshoe sitting here, and the distal anterior wall and apex are gone on flow. And with FDG, there's a slight increase here, and more pronounced is the return of normal uptake on PET in the septum. So this is a patient who has in the distal anterior wall, near the apex of the septum, a large area of hibernating myocardium that would benefit if blood flow could be returned. Just skip over that for a second. So here's case 1. This is one of my patients. He's 65. He had a recent MRI. He was ongoing ischemia, And ongoing ischemic chest pain, maximal medical therapy, his EF by echo was 45%. He was sent to the cath lab, and these will take a few seconds to start. You can see that there's something not there that should be there in the anterior circulation. It's an ugly looking vessel, and the question in this patient is there any benefit to attempting to revascularize that vessel, or is it hopeless? Is there anything out there? The echo showed the anterior wall to be severely hyperkinetic to akinetic. The infarct was recent, so there was a question of whether or not it would be worth to undergo either bypass or complex single vessel angioplasty to fix that vessel. I see Victor nodding his head, he just wants to do the angioplasty to get over it. So there we go. So in this set of images, it's a little different than you might be used to. The bottom row is the cystinoid or the flow, and the top row is the PET. And so if you look, for example, here on the cystinoid, again, there is no apex, and the distal half of the anterior wall is missing. And if you look at the top row here, here the apex is gone. And again, the anterior wall here on these images, which are the flow, the cystinoid images, there's a defect. This is the PET image, and although not great, there is a very significant difference in the distal anterior wall and apex in the PET images that you see on the flow images. And these images suggest that there is a significant amount of myocardium that's hibernating and it may benefit. And we go one step further, we actually quantify it. And the quantification map says that 21% of the myocardium is a scar, and that 28% of that is in the LAD territory. But hibernation, although diffuse, is again more than 21% of the LAD territory is hibernating, and another 19 in the anterolateral wall circumflex. And so this patient actually went on complex angioplasty in return with a significant improvement in symptoms, which is better than having complex angioplasty and no improvement of symptoms. This is the second case. This is a 75-year-old patient, hypertensive diabetic. He was seen a month post-MI with shortness of breath, chest pain, and he had an episode of syncope the week before. Again, as they play up, you'll see a significant abnormal angiogram, and something that I'll let Victor comment if he wants to, but not something I don't think an interventionalist would want to deal with. But the question may be, can this patient benefit from surgery? He has significant LV function, he has chest pain, he has significant coronary disease. Would he be better to be treated medically, or should he have something done? And this is his PET study done after the angiogram. And he has, on the flow images, a large defect in the anterior wall here, and the anteroapex here, distal anterior wall here. But unlike the previous one, the PET images are almost a complete match. There's very little difference between the flow and the PET images. The amount of salvageable myocardium appears small, and when you quantify it, you see that it's actually only 10% of the entire myocardium that's diffuse, that's viable or hibernating. In this case, there was really no reason to go on and do an intervention on the patient. So there isn't any question that if you revascularize the right patients, they do well. If you revascularize the wrong patients, they don't do well. And if you just medically treat patients with hibernating myocardium, it's not a good outcome. So the last question, is there any evidence to suggest how much is enough that we should actually proceed to do something about the problem? And that was answered in two parts by a study done in Ontario called Part 1 and Part 2. In Part 1, what they determined was that as you increase the amount of viability pre-revascularization, the amount of recoverable LV function went up. So if you had a large amount of myocardium, you had a modest increase in LV function. If you had a large amount of viable myocardium and you revascularized the patient, you had a significant increase in LV function. That led to some analysis that suggested that somewhere around 15% of the myocardium hibernating was enough to get a benefit, and that was Part 2. Part 2 was a study of 285 patients with grade 3 to 4 LVs, all of which had significant scar, and and underwent in a randomized fashion either PET or regular treatment, and patients who followed the PET treatment arm and had revascularization or not, guided by PET over a period of 400 days, had a significantly improved survival. And that's the standard that we now use to look at hypertrophic myocardium, and we estimate by quantitation about 15% of the myocardium. And if the patient had 50% or more, they get sent for revascularization. So, as I alluded to, detection of hibernating or viable myocardium is important prognostic indications. There are many methods, all of them valid and done appropriately for the determinant of hibernating myocardium. PET is a very good technique, but honestly, the decision really depends on what's good in your region and what you're able to do in your area. All